Welcome. This is Dr. Brian Chicoine of the Advocate Medical Group Adult Down Syndrome Center. And today I'm going to present on regression and loss of skills in adolescents and adults with Down syndrome. I am the medical director of the Advocate Medical Group Adult Down Syndrome Center in Park Ridge, Illinois. We are a primary and specialty healthcare clinic for individuals with Down syndrome, ages 12 and older. We opened in 1992, and we now are housed in the building there at the top of the Adult Down Syndrome Center. We have seen over 6,000 individuals with Down syndrome, and annually we see approximately 2,000 patients with over 7,000 visits. And we are on the campus of Advocate Lutheran General Hospital, which is in the lower picture there, again in Park Ridge, Illinois. So this is part of our 2020 Health Education Series, our first one here today on regression and loss of skills in adolescents and adults with Down syndrome. In April, we'll be presenting on behavioral changes in adolescents and adults with Down syndrome. And then in August, on sleep in adolescents and adults with Down syndrome. And then in November, on aging and Alzheimer's disease in adults with Down syndrome. Each of these presentations will be seen both live at the Advocate Lutheran General Hospital in the Johnson Auditorium, but they will also be recorded and then put up on our resource library on our website. So again, today's focus is going to be on regression and loss of skills. And the goal is going to be today on loss of skills and regression, and a little bit on Alzheimer's disease, but that's going to be primarily discussed in the November presentation. We've evaluated a number of people with Down syndrome who have lost skills, and we really want to try to answer, why does this happen? How do we approach it diagnostically? And what can we do to treat it? And what can you do to address it in your own homes and in your own work sites, etc.? So again, this is information is provided for educational purposes only and is not intended to serve as a substitute for medical, psychiatric, mental health, or behavioral evaluation, diagnosis, or treatment planned by a qualified professional. So people with Down syndrome can lose skills, unfortunately, from a variety of reasons. In childhood, autism is been found to be more common in children with Down syndrome than it is in other children. Again, this is a childhood onset illness, so typically at age less than 3 years of age, although it has been found that it can be a later onset or later diagnosis in some children with Down syndrome. And the etiology is yet to be determined. But again, it does seem to be more common in people with Down syndrome. We also have something we call, for lack of a definite title at this point, and we'll talk more about that shortly, we'll call regression syndrome. And this typically occurs later in childhood, adolescence, and young adulthood. And we're going to talk a great deal about that today. And then Alzheimer's disease in older adults. Again, this is in people that are typically more than 40 and is a progressive condition. And then loss of skills from a variety of other reasons, all ages, and we will talk about that as well. So again, the focus today is going to be on regression, what we're calling regression syndrome, and also loss of skills from a variety of other reasons. So what is this regression syndrome or regression that we're talking about? So I'm part of the Down syndrome medical interest group, and we have a part of that group is working on better understanding regression. And so we've come up with a working definition at this time. Now, again, this is not an official definition or even official name at this point. This is still something that's being studied and looked at. But at this point, we have a working definition to work off of. And so the core features would be a decline in cognitive or executive function, social withdrawal, loss of acquired skills, loss of functional use of language, and generally these conditions last more than 3 months. Now, we've had some discussion about whether we should take that more than 3 month duration out of the definition, because some people seem to respond better to treatment if it's addressed before 3 months or as early as possible. But that's the gist of it, is that this is a condition that does tend to last more than just weeks or a few months. Typically, these folks are between age 15 and 30, although we've certainly seen people that are younger and people that are older that develop this. And as best as we can tell at this point, the equal distribution between men and women. Other features that are more variable include maladaptive behavior, psychiatric symptoms, failure to acquire new skills, inattention or disorganization, motor slowing, vegetative symptoms such as appetite or weight loss and incontinence, and then sleep pattern disturbance. So, historically, where did this come from? So certainly, my interest goes back to being part of the Down Syndrome Medical Interest Group. Over the course of a number of years, at each annual meeting, we would talk about a few cases as people would bring up that had people that typically in this age range we just talked about in the 15 to 30 that had some decline in skills that were hard to define and typically fairly hard to treat. But again, there is not an official name, and so we've been trying to pool these cases together to try to get a better idea. But if you go back over the years, far back as 1946, Rolland described the development of catatonic psychosis in some people with Down syndrome. Prasher from the UK called it young adults with a disintegrative syndrome. Devaney and Matthews described a relatively rapid onset of decline. From Akahoshi and others described an acute regression. Worley described it as Down syndrome disintegrative disorder. Dr. Miles and the other colleagues described catatonia. Mercer described a regression, and then Dr. Capone and I wrote a chapter for a book on we called it adult regression syndrome. So again, a lot of names, a lot of different people looking at this without an official declaration of what this is and what it should be named. But again, now it comes back to the Down Syndrome Medical Interest Group and our work group that we're working on trying to sort through these things. And we're still learning, and this is a understanding in process. So let me just give you a case example, and I should tell you that this case is a sort of a conglomeration of people. This is not any one individual. So from a HIPAA standpoint, a privacy standpoint, I'm not describing an individual. This is sort of describing a conglomeration of different people that get built into one case presentation. So this was a 15-year-old girl. Again, this is an example of regression syndrome. This is a 15-year-old girl with Down syndrome who presented with a personality change. She was not, when we first met her, she had a personality change. She was not learning in school, having difficulty doing her schoolwork or caring for herself or learning new things. She had agitated behavior initially that was then followed by decreased movement, decreased eating, decreased interest in activities. This had been progressive over about 6 months, and she had gotten to the point where she was unable to go to school, move about the house, speak, or even feed herself. So again, just trying to give you an example of the level of complexity of this condition. So one of the questions is this a unique entity? Is regression a symptom, a syndrome, a unique medical psychiatric condition, or an illness? Can all regression be explained by present defined conditions or causes? Or is there something unique about some of these individuals that is not otherwise recognized perhaps in people that don't have Down syndrome, or is not explainable by the known entities that we know can cause a decline in skills? So let's then take a look at decline in skills. So this would be a little broader category that regression might fit underneath. You could think of it that way. And so why do people with Down syndrome have a decline? It's sometimes, not all, but why do some people with Down syndrome have a decline in their skills? And so that may be a decline in their cognition, their thinking. It may be a change in behavior or psychological changes. It may be a problem with the ability to perform activities of daily living. Or maybe some changes in motor function. So in general, a lot of the decline in skills would be less pervasive across a person's cognition, activities of daily living, physical abilities, mood, and behavior than what we get labeled as regression syndrome. So in a sense, decline in skills may be a milder form, if you will, but again, how these are interrelated is not understood at this point. But certainly, just in general, the decline in skills is not to the level of what ends up getting labeled as regression syndrome or one of the other titles that people have used. So one aspect may be changed, or a couple aspects, but typically not the breadth of the symptoms that you would see in regression syndrome. So is it regression or is it decline in skills? So typically regression tends to be more severe and more pervasive, and the cause can be the same in some instances. And initially it may look just like decline in skills, but manifest as regression over time as either more aspects of the person's decline are noted, or as it progresses into those additional areas of the person's life. Now, I should just pause 1 second and just make clear that so sometimes people will say something like, over the summer, my son regressed because he wasn't reading as much and his reading skills declined. Now that certainly is a form of decline in skills, although typically a more mild one, but certainly would not be in the category of regression that we're talking about, as we've seen the depth of challenge that some of those folks are facing. So again, that person might be regressed, but we would not certainly consider that regression syndrome per se. So what are the keys is to investigate why the person is declining. We want to do a thorough history and physical exam. We want to evaluate for contributing causes. And again, whether it's a less pervasive decline in skills or whether it's regression, the approach is similar. We want to go look to see what may be contributing to this change. Why is the person declining? And there may be a number of reasons. It may be a metabolic reason, diabetes or thyroid. It may be an infectious cause like Lyme's disease or something along those lines. It could be a trauma. Has the person had a head injury? It could be psychological, depression or anxiety. It could be a social issue. Has there been some stressor going on in the person's environment, a change in the family, or other things that have occurred that caused the person to function less well than they had previously? So as you look at this list, and there's multiple pages of this, you'll see that there's a lot of reasons why a person with Down syndrome can decline. It can be medical conditions such as sleep apnea, which is more common in people with Down syndrome, seizures, which are more common in people with Down syndrome. Vitamin B12 deficiency, we think, is more common in people with Down syndrome. Chronic pain, particularly dental pain, often gets underdiagnosed, and the people end up with chronic pain, and it affects the way that they function, which is not unique to people with Down syndrome. Most of us, when we have chronic pain, are not going to function as well. And that chronic pain may be menstrual or gastrointestinal, severe constipation. All those things may contribute to a person's decline in skills. Cardiovascular disease, uncorrected congenital heart disease with pulmonary hypertension and congestive heart failure, and Eisenmenger syndrome. Fortunately, we don't see too many of those folks anymore because children now are getting congenital heart disease treated as infants, where in the beginning of the clinic many years ago, many of those folks were born prior to the point where the ability to treat congenital heart disease was available. And so they were, in adulthood, were having a pretty significant decline in both their physical and cognitive skills based on poor heart function. And strokes are also another reason that people can decline. Infectious diseases, even things as sort of routine as urinary tract infections and pneumonia, but certainly more people more sick, sicker with sepsis and other infections that may cause them to be hospitalized. Numerous toxic or metabolic etiologies. Is there something that the person's ingesting or is in the environment that's affecting them? And then a wide variety of neuropsychiatric disorders, including catatonia, which is a condition in which people often have a motor change as part of their over symptoms. Now, in the past, catatonia was thought to only be associated with other mental health conditions, and particularly in the past, it was thought to be primarily associated with schizophrenia or psychoses. But then it was recognized it could be associated with other mental health conditions. But also, and then it was many people now think that it should actually be able to stand alone, meaning you don't necessarily have to have another mental health diagnosis to have catatonia. Classically, we think of catatonia as being someone that's sort of frozen or not able to move. but it's a motor dysfunction, so it can be that, but it also can be the other way, where people actually have sort of almost a hyper movement, where people will constantly be moving their fingers or rocking or other things that can be a part of the motor dysfunction associated with catatonia. It could be a mood disorder, depression, obsessive compulsive disorder. We have many people with Down syndrome have a tendency towards the sameness or repetition, and we call that the groove. But certainly the groove can become problematic when either the person is so stuck on doing that the person is unhappy or unable to control that repetitive behavior, or it can be a problem when it is just so problematic that the person is not able to function. For example, someone needs to close a door 43 times before they leave the house. And so they're always late for things. They're missing other activities. They can't get to school. They can't get to work, whatever the case may be, because they're so stuck on doing things repetitiously. And that certainly can be associated with obsessive compulsive disorder and can lead to a significant decline in function. And then we also see some post-traumatic stress disorder, and we think people with Down syndrome are probably a little more susceptible to that because of what we describe as a videographic memory. Many people with Down syndrome seem to have the ability to almost watch something and then be able to replay it in their mind, almost like they're watching a video, turning on a switch and rewatching what has occurred. So a very strong, even sort of beyond a photographic memory, but a videographic memory that they can then turn that on. Now that can be a lovely thing when it's a good event, but that can be very problematic when the event was traumatic and stressful, and can be very challenging for that person to replay that over and over in their head. And one thing about post-traumatic stress disorder I think is key is that sometimes that gets overlooked because what the person is finding stressful, or the event that the person found stressful, may not be stressful to somebody else. But stress is really in the eye of the beholder. And so what one person finds stressful may not be for you and I stressful, and what may be stressful for you and I may not be for someone else. And so that's one thing to consider. And the other thing is that we often don't get the history of what the stress was. So many times the people we serve, our patients, cannot describe what the stressful situation was, and so we don't really understand the post-traumatic stress component of this, but we certainly do see the symptoms of perhaps anxiety or depression or whatnot that they may have. Other conditions, hypothyroidism, hyperthyroidism, over and underactive. And then sensory, visual impairment, glaucoma, retinal detachment, cataracts, keratoconus. All these things can contribute to a person declining in skills. It is important, from my standpoint, is that I think that many people with Down syndrome, because of their cognitive impairment, have a more difficult time compensating when they lose a sense, whether it be vision or hearing, which is next there. And so they actually struggle more when they lose a sense than someone else might, because they have a more difficult time compensating for that change. And certainly, so hearing impairment, ringing in the ears, vertigo, the sensation of spinning, all those things can be very problematic and cause the person to decline. And again, as I mentioned about puberty with the life events, but certainly loss of family, friends, pets, school graduation, changing work settings, changing schools, going from grade school to middle school to high school, physical relocation, family moving, and then response to hospitalization or medical condition. We know that people who are hospitalized with or without Down syndrome will often recover from the condition that they're hospitalized for, but may have more difficulty recovering from the hospitalization itself, being in bed, having people take care of us, perhaps even being fed, or whatever the case may be. To regain those skills can be challenging for any of us, and certainly they can be for people with Down syndrome. And then autoimmune disorders, Hashimoto's encephalopathy. We know that autoimmune disorders are more common in people with Down syndrome, but their exact relationship to decline in skills is a little less clear. But things like Hashimoto's encephalopathy, Hashimoto's thyroid thyroiditis or thyroid disease is the most common cause of thyroid disease in people with Down syndrome. And it's thought that there may be a component that actually directly affects the brain. Pandas, in which someone's had a strep infection and as a consequence of the immune dysfunction or immune function that occurs in response to that, develop neuropsychiatric disorders. And then there's a whole list of other autoimmune diseases that may seem to probably contribute to this, although we still need to learn a lot more data on what that means and how that's what the implications of that are. So you go through all those and you try to make the diagnosis, and then so as far as treatment, the first thing you want to do is really treat a diagnosable condition. So if there's catatonia or autoimmune disease or sleep apnea or thyroid or B12 or celiac or whatever, you want to certainly treat the diagnosable conditions. You also want to treat the related signs and symptoms. So sometimes people will have depression as part of that. We talked about the other symptoms when we were talking about the definition, but there may be a depression that's associated with hypothyroidism or depression that's not associated with hypothyroidism, just the person is depressed. But sometimes, for example, depression with hypothyroidism is a common symptom of depression. It's a common symptom of hypothyroidism, excuse me. But treating the person with thyroid medication, and sometimes an antidepressant is required as well. So you want to treat the diagnosable conditions as much as possible. And then you want to treat the related signs and symptoms, and then you want to use therapies to help improve function. So to get people going again, we often find that when the person has a decline and we've treated the underlying condition, getting them going again can be the most difficult step. Getting them out of the house again if they're declining to leave the house, getting them to go back to work, getting them to function at school. How do we do that? And oftentimes therapies, physical therapy, speech therapy, occupational therapy, are important to help the person regain or improve their function. And then what we call safe activities. So to try to move a person forward too fast as they come out of this regression or come out of a decline in skills, if we try to move them forward too fast, sometimes we'll go 2 steps forward and 3 steps back. And when the person becomes frightened again of moving too forward too fast, then they will go backwards. Now, it's not a direct correlation story, but it certainly speaks to the need for safe or appreciating the person's pace that they can move. So Henry Nouwen, who was a Catholic priest who lived at L'Arche facility in Toronto, which is an organization that cares for people with intellectual disabilities, and he tells the story. The person probably actually had autism when he tells the story, but although he didn't specifically mention that. But the person had a very set routine in the morning, and A had to be followed by B, be followed by C, and be followed by D, and go through that, in a very precise and deliberate manner. Father Nouwen would at times recognize that if you tried to speed up the person, at some point the person would stop, that the routine had been altered enough that the person would stop. And he also discovered that if you that the person didn't just pick up where they left off, they would typically have to go back to A once again, and then B, and then C and D. So appreciating that the person has their own pace that they need to either function in that case or recover with regards to the issues of regression and decline in skills. To not appreciate that, we can actually bring ourselves further back than we started if we try to go too fast. So appreciating where the person is and trying to read them as best as possible to help them with in the recovery. I do want to mention one other thing is ECT or electroconvulsive therapy. In some of these folks that have catatonia, in addition to medications, ECT has been really a godsend for some folks. So in folks that have regression with the catatonia that are not responding to the medications either well or completely, ECT is a recognized treatment for this, and we've had some pretty significant success with ECT in some individuals. Certainly not for everybody, and just many of us think of ECT. We think of old movies that portrayed it in the old way that it was done, but certainly now it's done with an anesthesiologist, and it's done in a much safer and much more controlled manner than it was in the past. But again, not for everybody, but it is something that can be successful for people with catatonia. So I want to do a few case presentations just to give you a little better sense of this. And so we're going to start with someone that has regression. Again, these cases are built together. They're not any one individual. So I'm not violating anybody's privacy, but just have pulled together a number of cases to make a point. So this woman has regression. So it's Lucy. She's a 30-year-old woman with Down syndrome. She presented for her first annual evaluation at our center. And at that time, she did not speak during the assessment. She was reported to have no verbal skills at this time. She had repetitive motions through much of the assessment, had little or no eye contact or interaction with the clinician. At first glance, she appeared to have autism, but the history was not classic for that diagnosis, in that Lucy had been a typically developing girl with Down syndrome with mild cognitive impairment, good verbal skills, and good self-care skills who attended school and a variety of activities prior to age 17. According to her mother, Lucy developed an upper respiratory infection at age 17, was treated with an antibiotic, and suddenly regressed. Over the following years, she had an extensive workup, including blood tests, imaging, CTs, the brain, etc., and sleep study. And she had been given a variety of diagnoses, including depression, anxiety, late-onset autism, early-onset Alzheimer's disease, and psychoses. She had been treated with several psychotropic medications and supplements with little or no improvement. However, she did not display any further cognitive decline. So she had neither really improved nor deteriorated over a 17-year period. So that's one example of someone with regression. What about my 19-year-old? So this is not an uncommon question we get asked. Memory impairment. A person's developing some memory impairment. They're losing some skills. There's some behavioral changes. And they've been diagnosed with Alzheimer's disease. Now, so I get calls from lots of places, people asking about a similar scenario of a 19-year-old that has been diagnosed with Alzheimer's disease. Now, I've learned in medicine never to say never, because as soon as you do, you're going to get a case that is exactly that. But a 19-year-old with Alzheimer's disease, even with Down syndrome, in which we know Alzheimer's is more common, a 19-year-old with Alzheimer's disease would be exceedingly uncommon. I've never heard of it, and so I would say that it's very unlikely that's the situation, and there's probably a lot of other reasons, particularly this regression, that would be much more likely the cause. Another case is a situation with a medication side effect. So we'll call her Lisa, who's 27. She presented with a reduced interest in activities, apathy, altered sleep. She was just generally disagreeable. This had been a very pleasant woman prior to that. And as we piece back the history, she had been diagnosed with irritable bowel syndrome sometime shortly before all this had started, and been started on a medication called dicyclamine or Bentyl, which is a medication used sometimes for irritable bowel syndrome. And it really seemed to be that this was side effect of this medication, which we know can cause all those things. And so we recommended stopping the medication, and then again, had this kind of slowly at her pace, returned her to safe activities. We used a lot of visuals with her. She visuals that kind of helped direct her. It was schedules and helped guide her back to activities, which we found we're big fans of visuals. We think they have a real place in helping people with Down syndrome, not only in their daily life, but recover from illness. And she had a very nice return to her previous level of function. Sometimes it can be a secondary effect, and I'll call her Sandy, age 26, who presented with a depressed mood. She had a congenital shoulder injury. Around the time of birth, she had an injury to her shoulder. And so let's say she was operating, her left shoulder that had the injury was operating about 70% of the right shoulder. So it was pretty functional, but not as good as the other shoulder. So on a typical Chicago winter day, she had a fall, and she fell on her left shoulder. And now that left shoulder was only operating at about 30%. And she developed a depressed mood. So we evaluated her, and part of the treatment was an antidepressant. But we also referred her for physical therapy and a home exercise program to help get the shoulder back as close to possible. Now, we got it back to about 60 or 65%, never back to that 70% that she was before, but she had a significant improvement of the shoulder, which was a real concern for her and was really part of the drive towards her developing depression. And so it wasn't enough to treat the antidepressant. We also had to address the underlying effect that was the primary problem causing the secondary effect of depression and change in skills. Another case I'll describe as a real impact on the interaction, or describes the impact of the interaction between physical and mental health. So we know, for all of us really, mental and physical health are intertwined. And we know that's, if I don't feel well physically, I'm not as likely to feel well mentally. And this is particularly true for people with Down syndrome, we think, for a number of reasons. One, particularly because of communication issues, the inability to share what's bothering somebody verbally, or even in other forms of communication, can lend itself to either have it present as a behavior or cause a mental illness. So we'll call him George. He's 32. He presented with a depressed mood, loss of skills, and hallucinatory behavior. He was, for all intents and purposes, had psychoses, and we diagnosed him with such. And there was a question of whether this may be Alzheimer's disease, or regression. And as we listened to the history, and he had gained some weight in the last couple of years, and had started to snore louder, and also was noted to have some pauses in his breathing. So we sent George for a sleep study, and he was diagnosed with sleep apnea. And the very interesting thing with George is that he was able to use the CPAP, which is one of the treatments for sleep apnea. He was able to use the CPAP well, and all these other symptoms resolved. So not only did we treat the sleep apnea, but all the symptoms got better. And George actually never prescribed a medication, a psychiatric medication for George. The only treatment for this ended up really being the CPAP for the sleep apnea, and it solved George's issues. So what can you do as part of this? So that example is a good one, where the family and his assistant had recognized the weight gain and the snoring and the pauses. So really it was very helpful with regards to the history to help us guide us towards the correct diagnosis and treatment. So the first thing we encourage is be observant. There are many causes of decline, as we have discussed, and so you want to observe. Is there something, might be sleep apnea? And the other piece is and then share your observations, certainly with the healthcare provider who's assessing the individual. And then don't assume, don't assume that this is just a decline for which there is no potential treatment, or that there is, it's just Alzheimer's disease, or whatever the case may be, or in older folks, or untreatable regression or something. There are lots of reasons. So it may be something as relatively simple as cataracts, or ears that are full of earwax, cerumen, or a thyroid problem, all of which are fairly readily treatable and can cause significant decline in skills if untreated. And then helping a person resume function is often harder and comes later than improvement of the underlying condition, as I've mentioned. And so that's again where you would play a big role in helping the person restore function with the safe activities, and then reteaching them. So even if the person has lost these skills, they have to really relearn things that they had learned in the past. They aren't just going to necessarily come back as the person feels better. And then trust yourself. I think that's the key. Families and caregivers, listen and watch, and you know the person with Down syndrome likely better than I do, or the healthcare provider, and trust yourself, and share your observations, and be part of the team to help the person get better. So that's the end of the presentation, and on decline in skills and regression. again, in a sort of a summary, you can think of decline in skills as a fairly broad category, and in young age, autism may be a cause of decline in skills. In the more adolescence and early adulthood, we see this regression syndrome. And then in older adults, we see Alzheimer's disease. And then across all ages, we see a variety of health conditions that can contribute to a person to have a decline in skills or even regress. And so lots of assessment and evaluation is important, and sticking with the person and helping them keep looking for contributing causes. What you find on the first visit may not, there may be other causes that you find over time. And again, this is oftentimes a gradual reintroduction into life. Even after the person is feeling better, the physical and the mental health conditions may be addressed, but the person, as far as the functional piece, that may be a little slower to come back, and it's typically slower to come back. So it's certainly something to think about. So please, thank you for joining us, and if you have any questions, you can see on our webpage that there is a way to submit questions. And again, feel free to join us on the other presentations, either live or seeing the recordings as they get put up in the future. So again, thank you very much. Have a great evening.